So question number 1 is a 30-year-old woman coming for a routine health checkup. And in the clinical vignette, if you find this word written as a routine health checkup, that means the patient is mostly asymptomatic. Patient is mostly asymptomatic. Now, what are the patient complaints? Patient give a history of slight increase in the yellowness of eyes during the prolonged fasting and whenever there is stress. So this is episodic yellowness of the eyes. Yellowness of the eyes means that there is icterus. There is icterus. There is no significant past medical history. She is not taking any medications. She does not consume any alcohol. So these are the points in the history which are being asked. The causes of the jaundice has to be ruled out, whether it is a drug-induced icterus jaundice or it is alcoholic liver disease. So on examination, icterus is present. So I will say icterus is present. There is no pallor, no hepatomegaly, no splenomegaly. And after this examination, if icterus is present, what will be our next line of investigation? The next line of the investigation here will be, we will do a bilirubin levels to see that jaundice is due to the high bilirubin or not. So the important words here or the discussion here is what is the level of the bilirubin for icterus. So important questions which can arise, that icterus comes when the serum bilirubin total values, serum bilirubin is more than 2.5 milligram per deciliter. And the second will be what are the other causes of the yellow eyes. So the yellow eyes can be because of some drugs, drug induced, like anti-malarials. They can cause the yellow eyes. So this is not given in the history. There is no drug history which is present here. Now when the serum bilirubin is high, so what we should do if serum bilirubin is high? We should fragment it into two types, whether it is a unconjugated bilirubin or a conjugated bilirubin. So we will fragment into two groups. The causes of the unconjugated bilirubin are few causes like hemolysis or Gilbert syndrome, Crigler-Najjar syndrome, and some drugs. They can cause unconjugated bilirubin, unconjugated bilirubin. So based on this information, if we analyze our patient's report, so patient report says that there is increase in the unconjugated bilirubin. So the causes here can be Crigler-Najjar syndrome. So you should think like a differential diagnosis. What could be the causes here? Crigler-Najjar can be the cause and Gilbert syndrome can be the cause. So how to differentiate which is the best option out of these two? So the best option is Crigler-Najjar syndrome is usually a severe syndrome and it is present in childhood, while Gilbert syndrome can present at any age. It can present at any age. The important feature of Crigler-Najjar syndrome, there can be kernicterus history. The brain abnormality can be there. While Gilbert syndrome, characteristic feature is that jaundice, the symptoms of jaundice, they increase on any stress, like patient is fasting or patient is having any sort of lack of sleep, that is also a stress, so jaundice will increase. So based on that, we have made a analysis. This is unconjugated bilirubin, causes can be Crigler-Najjar or Gilbert syndrome. Out of these, how will we choose the best option? If it is a single best, answer is the Gilbert syndrome. Gilbert syndrome. While Dubin-Johnson and Rotor syndrome, they are associated with conjugated bilirubin elevation. Here, conjugated bilirubin will be elevated. So this is how we have to analyze a clinical case or a clinical vignette which is coming to us. Now, moving on to the next one. So hopefully all of you have given me the correct answer. Yes, most of you have given me the correct answer. All right. So scrolling on the right side. So right side is icterus occur. This is the viva question also. Next two is mainly a viva question. So this will be useful for the next two exam as well. The icterus occur when the bilirubin levels are more than 2.5. Other causes of the yellow eyes are anti-malarial drugs. It can be drug induced. And serum bilirubin elevation can be unconjugated or conjugated bilirubin. Unconjugated important causes are hemolysis, Gilbert syndrome, Crigler-Najjar, and the drug induced. Now, moving on to the next one. So we move to the next one. So the next one is, yes, these PDF will be shared. So my advice is that you should participate in the clinical analysis so that you develop that habit of thinking process in the exams. How to conclude depending on the clues given to you which particular disease patient is having. Now come.
This is the first question. 55-year-old HIV male patient presented to the emergency department with recent onset of dyspnea, pleuritic chest pain, and dry cough. On examination, he was febrile with low blood pressure, oxygen saturation of 82% on room air, and respiratory rate of 22 per minute. He had shallow work of breathing with right-sided absent breath sounds. His recent CD4 count was 150 per microliter. Emergency, bedside chest X-ray is shown below. What is your diagnosis? Now see here, the important points here is patient is having acute presentation. There is hypotension. And most importantly, absent breath sounds. Then if you see the chest X-ray, there is hypertranslucent air-filled area. So this everything is air-filled area. Along with this, what do you notice here? A compressed lung margin with shift of mediastinum to opposite side. This is a classical scenario called as tension pneumothorax. Now, in the next exam, they might ask you the same clinical scenario. Either they'll ask you the diagnosis or they might ask you what is the next step in management, next step in treatment. Because patient is in hypotension, it means patient is having tension pneumothorax. Your answer should be needle insertion needle insertion followed by ICD. So in acute setting, whenever you get shortness of breath, there are few conditions that you should never forget. So I will tell you the answer for this question. Whenever there is acute shortness of breath, I ask my postgraduates to remember with an alphabet called as P. So acute shortness of breath. So usually within minutes 2 hours, patient will say that, doctor, I was absolutely normal. Suddenly I have developed shortness of breath. First P is pneumothorax. Next P is pulmonary edema. So it can be due to myocardial infarction. So can anybody tell me the third P that you should never miss but you usually miss? It is pulmonary embolism. So whenever some patient is with shortness of breath, so think of these three DDs. Now extra edge, it can also happen in pneumomediastinum. And don't forget this P called as pre-existing illness, worsening. Suppose patient might be having asthma. Tonight he might be having a date with a girl in his class. He must have taken Axe deodorant, complete bottle. Now Axe effect, because of that strong odor, he develops exacerbation. So this is the Axe effect for asthma patient. Then, if at all history is suggestive, any aspiration of foreign body. So this fellow, instead of going to a date, he went with his buddies for a party, had a lot of alcohol. Later, instead of putting chicken into his stomach, he put it into his trachea. Aspiration of foreign body. So whenever there is acute shortness of breath in a clinical scenario, pneumothorax, pulmonary edema, pulmonary embolism, pneumomediastinum, pre-existing illness worsening, and aspiration of foreign body. So in this scenario, whenever you get chest pain, shortness of breath, and hyper resonant note, blindly, what should be your answer? Your answer should be pneumothorax. Your answer should be pneumothorax. Okay, done, students. Acute shortness of breath. Tomorrow, if you are an intern or a duty doctor or a physician, make sure you don't miss these conditions. You don't miss these conditions. So, acute shortness of breath in emergency department. This is what I generally tell to my postgraduates or my interns. Most important is not investigations here. Here, patient's clinical history is most important. So when there is somebody with shortness of breath, most important is clinical history. So first, instead of sending him to chest X-ray, ECG, 2D echo, referring him to all specialists, first clinically examine him, because clinical data will give you a lot of information why shortness of breath is happening in his. So clinical data. So is there any pre-existing illness such as asthma? Suppose he is an asthmatic worsening in the emergency department, mostly acute severe exacerbation of asthma. There ends the matter. Is he having pre-existing COPD or a coronary artery disease or CKD who missed his dialysis? Now he might be in fulminant renal failure, or there is any CLD or diabetic who missed his medication insulin, now can come with diabetic ketoacidosis, which will also result in acute presentation. Any thyroid disorder, especially hyperthyroidism. So hyperthyroidism patient can also present with arrhythmias in the emergency department, can have acute shortness of breath. So whenever a patient is there with acute shortness of breath in emergency department, ask these questions. What were his pre-existing illness? If there is a COPD, most probably it must be COPD exacerbation. Next question. Associated chest pain. Chest pain and acute shortness of breath. What are the conditions? Again, the usual culprits. Can it be pneumothorax? Can it be pulmonary embolism? Can it be pulmonary embolism? So can it be pulmonary edema due to myocardial infarction? So patient in the emergency department, acute chest pain and shortness of breath. So it can be any of these possibilities. Any fever? Can it be any pneumonia? So any orthopnea? Can it be any cardiac failure? Can it be any cardiac failure? Each and every point is very relevant. So what I am going to teach you here is not just for your exam, for your day-to-day practice in emergency department also. And is there any immobilization history? So can anybody tell me why immobilization history is very, very important? This patient might be having recent air travel, or he might be bedridden patient now coming with acute shortness of breath. So any chances of pulmonary embolism, because if you take this history, so you will know what to focus next on this patient. Then examination findings, if there is pallor, so any chances of anemia responsible for this acute presentation. So if there is bilateral pedal edema, if there is any bilateral pedal edema, so any chances of kidney disease, any chances of heart disease, any chances of liver disease. Then JVP, if it is raised, most probably it can be failure, cardiac failure. Then chest examination findings. Is there any wheeze? Wheeze indicates obstructive airway disease such as asthma, COPD. So any fine creps on auscultation. Now tell me, students, acute shortness of breath in emergency department, fine crepitations on auscultation. What will you first suspect? Is there any pulmonary edema? Is there any pulmonary edema? Then, is there any absent breath sounds? Absent breath sounds and hyper resonant note. Absent breath sounds and hyper resonant note. What will it suggest? It will suggest pneumothorax. It will suggest pneumothorax. Then cardiac examination, any abnormal heart sounds such as S3, S4, which indicates failure, or are there any murmurs? So see here, students, whenever there is a patient with acute shortness of breath in emergency department, most important is not costly investigations. It is simple clinical history. So by clinical history, you should find out what might be the reason responsible. And if there is a conclusive evidence, asthma patient worsening in the emergency department, no need anything, just give him bronchodilators. If there is a already known heart disease patient now worsening, give him diuretics. If there is a diabetic patient worsening, you can give him saline insulin. So if conclusive, treat appropriately and investigate only if further if necessary. Then what are the investigations? So first line of investigation to rule out what is common. What is common? So CBC, chest X-ray, ECG, 2D echo will rule out common lung and heart diseases. So common lung and heart diseases. So fine crepitations is a sound heard by your stethoscope Jatin Verma. So whenever there is fluid in alveoli, there can be fine crepitations. Then coming to the second line of investigations. So you might need to send the patient for ABG, RFT, LFT. So these are renal function test, liver function test, any serum ketones to look for any diabetic ketoacidosis. Because acute worsening can be due to renal failure, can be due to liver failure, and glucose, hyperglycemia. Then thyroid profile to rule out hyperthyroidism. So all these second line investigations should be done to rule out metabolic or any organ dysfunction. So just wait for some time, Shruti. So don't be very anxious. So I'm going to tell one by one. So I think whenever somebody comes to Shruti in acute situation emergency department, instead of treating common things, she will be taking an ABG. So just wait for a while. So ABG is not the first line investigation. Okay. Then next, if you think in terms of pulmonary embolism, you can do a blood test called as D-dimer, CT pulmonary angiography. This is how you have to approach shortness of breath in emergency department. So first clinically examine and find out what might be the probability. Sir, how CKD lead to shortness of breath? So Swarangi Shri. So CKD, what will happen? There is nothing going out from your body. So there can be pulmonary edema. Okay. Then in CLD, chronic liver disease, what is going to happen? Decompensated liver disease. There can be ascites, lot of ascites. So if there is you eat 5 biryanis, so will you not get shortness of breath, Tejasvi Shanai? Now there is 5 liters of fluid in the abdomen. It will not allow respiratory muscle to function. Then what can be the other reason? There can be pleural effusion in chronic liver disease. Sir, why hyperthyroid causes chest pain? Who said hyperthyroid causes chest pain? Pravina Santa, I think you are sleeping. Kindly wake up. So hyperthyroidism causes shortness of breath. I did not say chest pain. Okay. So all these slides will be uploaded. So you're asking the same question again and again. So it will be uploaded. So I hope it is clear. So whenever there is acute shortness of breath in emergency department, so make sure you approach like.
A 55-year-old diabetic gentleman presented to the clinic with complaints of diarrhea and fever of 5 days duration. He had attended an office dinner before the onset of symptom, and he is a known diabetic for the past 6 years and agrees to have poor compliance with diet and medications. So yes, so what are the risk factors for having any defects? Number one, patient is an elderly and diabetic male patient is there. You don't have to note down the question, Sudhanshu. So for all the students, after the session is complete, I'm going to prepare the PDF and give it to you. So you will have the questions also, and you will have the PDF which is filled with the explanation also. So I want you to just participate. Again, I'm going to tell you, yes, you must type the answer, but also remember whether you got the journey to the answer right. That is equally important. So, क्योंकि मैं क्या कहता हूँ, that getting the answer sometime may be just good luck, but knowing the explanation for your answer is what we want to learn in this clinical discussion today. So you don't have to write down the question, you can just understand the case scenario. So patient is an elderly person who has developed a diarrhea and probably due to the abnormal food intake, and that has started the symptoms. Since he is a diabetic for the past 6 years and with poor compliance, that is a risk factor for renal disease. So what does the laboratory investigation reveal tell you? So number one, that the hemoglobin. So the PDF, wherever you have got the videos, in the same section, we'll put the notes, right? In the clinical live cases, we'll be able to fit that in. So laboratory investigation revealed the following findings. One is hemoglobin is 14.2, that is normal. The WBC count is elevated, which is corresponding to the infection. So there is definitely an infective etiology, that is sepsis is present. The platelet count is normal and urea and creatinine are elevated in this patient. So urea and creatinine, when they are elevated in a renal function test, the first thing that any student calculates is the urea divided by the creatinine ratio. The urea divided by creatinine ratio is definitely the ratio of urea divided by creatinine is more than 20:1 in this situation. The urine analysis shows that there is no proteinuria, no hematuria, and the presence of hyaline cast, which is considered the most benign finding in the urine routine. Considered the most benign finding in the urine routine. The spot urine ACR is 6.3. So tell me, is this microalbuminuria? The spot urinary albumin to creatinine ratio is also normal. This is also normal, we can say. And ultrasound report is also normal. When everything is normal, you think that most likely the patient is suffering from a case of acute kidney injury. Patient is suffering from a case of acute kidney injury is our diagnosis. That is definitely right. Short duration of symptom is there. Ultrasound is normal. It favors diagnosis of acute kidney injury. So is it an acute gastroenteritis with a prerenal azotemia or a tubular necrosis? So definitely it is not diabetic nephropathy. It is not CKD. So that takes care of B also. So two problems remain. The acute gastroenteritis with prerenal and tubular necrosis. So what we are getting the answer? Because the ratio is more than 20:1. It favors the diagnosis of the pre-renal AKI. Favors the diagnosis of pre-renal AKI and absence of proteinuria. So what we can say? There is a normal urine analysis which excludes renal injury, and that is why it is not tubular necrosis. But the best answer would be acute gastroenteritis with prerenal AKI. Best treatment diagnosis would be gastroenteritis with prerenal AKI. So yes, muddy brown cast again, Santhya, are specific, not common finding. We do not need always the muddy brown cast to be present in a case of AKI. So diabetic nephropathy, Sarthak, is a case of CKD. Diabetic presents with a chronic kidney disease and patient is a case of acute kidney injury, and that is why it is not a diabetic nephropathy. So what is the thing? What is the thing? The spot urinary ACR. So we want normal range of albuminuria. The normal range of the spot urinary ACR, albumin to creatinine ratio, is going to be less than 30 milligram of albumin per gram of creatinine. Less than 30 milligram of albumin per gram of creatinine will be normal ACR. Will be the normal ACR. Yes, no problem. Welcome all of you. I am going to give you the differentiation table, but again we will start with that. Of course, so we have completed. We want to understand that again from the beginning. So patient is an elderly gentleman having acute gastroenteritis following an office dinner. Since he is a diabetic nephropathy, he is prone for developing chronic kidney disease. But laboratory investigation reveals hemoglobin is normal. Hemoglobin is normal, right? Why do we do urine analysis? Oh my God, Rishav Raj Tiwari, ऐसे मत question पूछा करिए बेटा, है ना? So what is the idea here? The urine analysis is a part of the baseline investigation in entire medicine. I have told you repeatedly that whenever any medicine person, any medical condition comes, what test will you do in all the patient? These are part of the baseline laboratory investigation in all cases of medical disorder. You are going to do CBC, ESR, you are going to do serum creatinine and urine routine, and you are going to ask for blood sugar random. Serum creatinine, urine routine and blood sugar random. This is part of baseline investigation which you will do in all the cases of medical disorder. Even if you had not done the urine before, when the patient is having abnormal creatinine, you are going to do a urine analysis also as a part of our investigation. Yes, so hemoglobin is normal. That is favoring a diagnosis of acute problem, because in chronic kidney injury, we are expecting anemia to occur. So number one, hemoglobin is normal and the urea creatinine ratio is more than 20:1, which is important for diagnosis of prerenal. It is important for diagnosis of prerenal. The urine analysis is showing normal. There is no cast suggesting nephropathy, and the spot ACR is also normal, indicating there is no diabetic nephropathy. No diabetic nephropathy we want to see, and ultrasound is also normal. Hence we say it favors a diagnosis of acute kidney injury. Favors a diagnosis of acute kidney injury, and that is why number one, we ruled out diabetic nephropathy. We said it is not diabetic nephropathy because diabetes is CKD. Why not tubular necrosis? Tubular necrosis is a part of renal AKI. It is a part of renal AKI, and there will be presence of nephropathy, granular cast with there can be proteinuria. So all that is not there, and that is why it is not the acute tubular necrosis. Not acute tubular necrosis. And the best single answer is acute gastroenteritis with prerenal AKI. So all of you with the hundreds of questions in your mind, okay, be patient, okay. With every question, I'm also going to give you the approach chart, the flow chart to the question, so you understand it better. Come on, let's come to the next step. So along with each question, I want you to understand the simple clinical approach based on which we are able to understand the question, right? So approach to renal disorders, acute versus chronic kidney disease. So how to differentiate when patient comes with elevated renal creatinine? The first step is to differentiate acute versus chronic kidney disease. So to differentiate between the two, the most important is the corticomedullary differentiation on the ultrasound. Is the corticomedullary differentiation on the ultrasound. So if the patient is having acute kidney injury, the corticomedullary differentiation will be normal or preserved. The corticomedullary differentiation correlates with the anatomy, structure of the nephron. Hence, the patient will have the normal or preserved CMD. The size of the kidney will be again normal or enlarged kidney. Normal or enlarged kidney. The urinary cast you will find is the hyaline cast, which is considered non-specific for the diagnosis. It is a common finding in the urine but non-specific for the diagnosis. Anemia is going to be the rare feature of acute kidney injury, and metabolic bone disease is never present, because bone disease occurs only when the duration is more than 6 months. The bone disease occurs only when the duration of the disease is more than 6 months, and that is why it is never present in the patient of AKI. But if it was CKD, the corticomedullary differentiation may be normal or lost. Lost is specific. The size of the kidney may be normal or shrunken. When it is shrunken, it is specific. The presence of broad waxy cast is specific for a chronic kidney disease. Anemia is common finding, and bone disease, if present, is specific for chronic kidney injury. You want to look at any one of the features. So again I will tell you, so when the patient, what are the points that whether the patient in gastroenteritis, how can patient get renal failure? So understand the relation. In gastroenteritis, there are two risk factors. One, the patient is having sepsis. Other, the patient is having dehydration. One, the patient is having sepsis, and other, the patient is having dehydration. The sepsis also can lead to the microcirculation. Mechanism I am writing. The sepsis disrupts the microcirculation of the tubule. Endotoxin can disrupt the microcirculation of the tubules, leading to acute tubular necrosis. Can occur, and that is why it was one of the options. Number two, the dehydration can also lead to the prerenal AKI. It can lead to the prerenal azotemia. These were the two options given to us in the question, right? So what is the significance of the urinary ACR? The urinary ACR is significant because it is the earliest marker. If it was positive, it would have been the earliest feature of the diabetic nephropathy. Earliest feature of diabetic nephropathy. So that is why I had included it in this question, right? So included it in this question. So what we want to know, in gastroenteritis, the patient could have had the CKD because there was also underlying diabetes, which is not there now. Okay. So again, I'm going to request you, all of you are typing random questions. Yeah. And again, this is not a revision of the notes. What we are doing is a clinical approach to the given question and how to solve similar questions in the patient, in the exam. So whenever you get, now again look back at the question. Now once you know this, again look back at the question, that when the patient came with the acute gastroenteritis and patient had diabetic nephropathy, there were risk factors for both. Diabetic nephropathy could have led to CKD. The sepsis could have led to both. The acute tubular necrosis also, pre-renal AKI also, both were possible. So first step is to differentiate whether it is acute or chronic. Why we said it is acute? Because one, hemoglobin is normal, the urine is normal, and ultrasound is normal. So 1 + 2 + 3, all three favored the diagnosis of acute kidney injury. All the 3 points favored the diagnosis of acute kidney injury. Once we know it is acute kidney injury, we had only 2 choices. Either it is gastroenteritis leading to the dehydration, or it is tubular necrosis. So to differentiate between the two, we looked at the urea creatinine ratio. Urea creatinine ratio favors the diagnosis of pre-renal AKI, and tubular necrosis is a renal AKI. It could have come with granular cast and proteinuria, which are absent in the urine routine, and that is why we made the diagnosis that it is dehydration leading to pre-renal AKI. That's the point here. So don't worry, I will make sure that all of you are satisfied. So in this patient, what is to explain? Spot urinary albumin to creatinine ratio is to test for the presence of albumin urea. It is to test for albumin urea. Yeah, it is urea, blood urea divided by creatinine. You look for the blood urea divided by creatinine. That is the answer for you, Siddharth. Okay, so take your time. Each parameter we want to understand to know interpretation of the large test. To know the interpretation of the last test. Yes, so we'll come one by one. I want you to focus on clinical approach to the question. Please remember, this is not a test to answer. And again, I will tell you, in the next exam, it is also a passing as well as a competitive exam. So at least 50% questions are going to be basic approach questions, which you should not make an error in. You make an error in basic questions, your rank, trust me, will go down. So that's why point is again to focus and go to improve on our questions. So what we understood, first step, approach to the patient of renal disorder. I hope everybody is clear with that. Yeah. So Asim, what if the thing is less? So I'm wanting you to wait for the next question because 20 questions दिया है ना मुझे, तो let me get the chance. 20 question के बाद भी जो doubt है ना, मैं आपके लिए बैठा हूँ ना. So पहले एक एक क्वेश्चन में एक एक अप्रोच आपको सिखाते जाता हूँ. end of the session, you tell me whether the whole point has become clear to you. Okay.